this is a very important paper because today we have some guidelines. We have ELN guidelines, so European Leukemia Network guidelines, and the NCCN guidelines, which are not the same. So they're suggest in some in a podgroup of these FLT3 positive patients, they're a little bit contradictory. So this is why this paper is important. So FLT3 mutation is a known worse outcome predictor mutation, and it can occur in approximately third of AML patients. Usually means higher proliferative disease, higher burden disease, worse outcome, more relapse. But in FLT3 group of patients, it is also important to know, well, I'm mostly talking about, because in FLT3 we have FLT3 ITD mutation, and then FLT3 TKD, which is much less common. But in FLT3 ITD, then it's also important to know the allelic ratio, so from wild type and the mutated part, and also the co-mutation status, where the MPM mutation is important, because data show that patients who have a low allelic ratio and an MPM mutation could go to allogeneic transplantation in first relapse. However, then when you read the NCCN guidelines, they recommend still allogeneic transplant for all the patients who are FLT3 positive, while ELN consider these patients to be up for allogeneic transplantation, not upfront, but when they reach first relapse. Of course, problem with this, there are no prospective studies. The threshold for this ratio is 0.5 because most of the data correspond to this threshold. However, some of the studies have been evaluated on a higher threshold of 0.70 and higher. So, of course, techniques are not standardized, threshold is not standardized, and there are many questions always rising. Here also, there's a special group of patients which is, according to the ELN's guidelines, considered to be intermediate, so that these are the patients which are NPM negative but have a low allelic low ratio, which then these patients could be all transplanted, or we could follow them for minimal residual disease. But however, FLT3 is not a good marker to be followed, while and if they don't have an NPM, we cannot follow NPM. So according to the our position statement paper, only patients who have low allelic ratio and are NPM positive can be considered to be transplanted after relapse and not upfront. And all the other patients, if they're FLT3 positive and NPM negative, should be, irrespectively of the ratio, should proceed to transplant. Of course, the FLT3 AMLs are changing. The field is changing because today we are improving the pre-transplant setting, the transplant setting, and the post-transplant setting. Pre-transplant setting is improved because today we have FLT3 inhibitors which are added to standard induction and consolidation treatment as a result of the RATIFY trial. And this, of course, means that patients can go into transplant with less minimal residual disease, which has always been proven as the most important predictive factor for relapse after transplant. Secondary, then in the transplant setting, transplant is of course improving. Patients, if they don't have donors, they have haplo donors today, and with haplo being today not too toxic, I mean, transplant with transplant-related mortality, which is comparable to other donors with very good results. Haploidentical transplant is also becoming the standard, and transplant itself has improved with improvement of transplant techniques. And of course, the post-transplant setting has improved as well, because today we have the maintenance with FLT3 inhibitor as well. So to summarize, 4 indication for transplant are in our statement paper when it comes to when it comes to indications for transplant. Patients who are FLT3 low allelic ratio and NPM positive can be considered for transplant, not upfront, but in first relapse. All other patients should be considered for allo transplant. There's no difference when it comes to different donors or different conditioning. Conditioning studies have shown that different conditions and different different donors are equally effective. What it has been shown from a big EBMT study that ATG, the addition of ATG in the conditioning regimen, does increase chronic GVHD without increasing rates of relapse. So EBMT, Acute Leukemia Working Party, suggests to add ATG. And when it comes to post-transplant setting, we also agree, because most of the published studies, most of proof that we have is on sorafenib. So the position statement paper suggests the use of maintenance with sorafenib in a dose of 400 milligrams. And this maintenance should be, it's a prophylactical setting, so it should be introduced as soon as possible after transplant, and it should be stopped only if there is GVHD which requires systemic immunosuppressive treatment, and it should be given for 2 years after transplant. So the maintenance should be continued in up to 2 years after transplant.